And so our next speaker is, I have the pleasure of also introducing Dr. Johannes Czernin. He is the professor of molecular and medical pharmacology at the David Geffen School of Medicine at UCLA. He received his MD from the University of Vienna and is board certified in nuclear medicine as well as internal medicine in Austria and as well as in the US. He was named director of nuclear medicine at the David Geffen School in 1996 and currently serves as the chief of the Amundsen Translational Theranostics Division, also at UCLA, which includes the Nuclear Medicine Clinic, a clinical imaging research program, a drug and probe development program with a strong underpinning in tumor biology, a preclinical imaging and biomedical radiochemistry center. His group successfully applied to the FDA for an NDA for a PSMA-targeted PET imaging probe in prostate cancer. And his Theranostics division collaborates with multiple departments, including urology, radiation oncology, pathology, and others. Dr. Czernin is currently editor-in-chief of the Journal of Nuclear Medicine and is a past president of the Academy of Molecular Imaging and has published more than 290 peer-reviewed research papers. And so with that, I would like to transfer over to Dr. Czernin's presentation. We will not have questions at the end, but feel free to enter those into Slido, and we will definitely address that with Dr. Czernin.
I'm very honored to be part of this symposium that is dedicated to Sam Gambhir. I met Sam in 1989 when he was an MD PhD student, and I started a postdoctoral fellowship in Heinz Schelbert's group at UCLA. We later trained together in nuclear medicine and took our boards together in 1996. Sam was already remarkable as a student and later on, of course, as a scientist and as a great visionary. But what people may not have recognized sufficiently is that he was equally remarkable as a humanist. My family and I were among the many that Sam helped when we needed it, and I will always be very grateful for what he did. Here are my disclosure statements. Sam moved molecular imaging forward, and this shows some of the early work he did. This is a picture of young Sam here on the left side. That's how he looked, what he looked like when we met. He got involved very early on in promoting PET, first of all, as something that he felt could improve patient care in oncology, cardiology, and neurology, but also then to create the foundation to move forward towards recognition of PET as a valid diagnostic tool in oncology with subsequent Medicare reimbursement. The first studies that he did were actually very different from what he did later on, and these were analytical decision models for the cost effectiveness of various cancers and here in this case solitary pulmonary nodule. This was called decision tree sensitivity analysis, where he compared 4 different strategies in lung nodules: wait and watch, surgery, CT plus PET. And he actually found out that the combination of 2 imaging modality proved to be cost effective, meaning less expensive than the other strategies that are outlined here. But he went beyond that and created a monster work in a supplement of the Journal of Nuclear Medicine that came out, I think, in 2000. It was a tabulated summary of all the PET literature. This was really his work with a small group of people who helped him doing this and putting this together. There was many months of work to tabulate all the evidence that had been created to support the regulatory approval of FDG PET in oncology, cardiology, and neurology. That was one of the cornerstones to subsequently get early reimbursement for FDG PET imaging in lung cancer and solitary lung nodules. He also had this very playful nature, and together with Mike Phelps, he developed a platform called Let's Play PET. You still can find this on Google. They had listed executive producers: Mike Phelps, Sam Gambhir, Mahoney, and Marker. And this was to promote PET through educational efforts. Now, since the 1990s, there was much progress in PET imaging. Subsequently, of course, PET-CT imaging. First of all, there was Medicare reimbursement and then clinical adoption. There are now 2.5 million PET-CT studies performed in the United States every year. There has been remarkable progress in instrumentation with the emergence of total body PET imaging, recently introduced by Simon Cherry and Ramzi Badawi. That's a sea change in what can be done with PET imaging. And through greatly increased industry interest, there are now numerous PET probes, PET tracers commercially available, FDA approved, and becoming part of NCCN guideline and reimbursed by private and public insurances. The quality of clinical trials has markedly increased. You see here the icons of New England, Lancet Oncology, Lancet, JAMA Oncology, and JAMA. This is where now leading clinical trials addressing either diagnostic, therapeutic, or theranostic nuclear medicine approaches studies are published. And there was a recent editorial in the Journal of Nuclear Medicine by Mike Hoffman, who calls out the nuclear medicine community to keep improving and change the practices with prospective, high-quality data. And he refers to these as unbiased, prospective, multi-center diagnostic and therapeutic trials. These, of course, mostly evolved around theranostic approaches in the recent past few years. But for an understanding of the future, we need to look to the past. And these were actually the first studies in patients with hyperthyroidism, the first theranostic pair in this case, 123 iodine for imaging. That was not done in this case, but treating hyperthyroid patients with 131 iodine. This is actually taken from the notebook, the handwritten notes from Saul Hertz's lab, documenting the administered activities and outcome in 9 of 29 non-responders to radioiodine therapy. And as you can see, one of the reasons probably for non-response was the underdosing of these patients, a problem that we still face now, as I will hopefully show later on. Treatment of hyperthyroid patients was followed a few years later by treating the first thyroid cancer patients. And because of the targeted and selective radiation, the treatment was extremely well tolerated. In fact, this approach gave rise to the field of molecular radiotheranostics. And this is what we have now, and this is what is coming. The current and emerging theranostic pairs. Currently, we have iodine, of course, 123, 124 for imaging, 131 for treatment. The target is the sodium iodide symport. We have gallium and copper dotatate targeting somatostatin receptors in neuroendocrine tumors. We have iobenguane targeting the norepinephrine transporter, and of course we do have PSMA. These are established. These are FDA approved. They are reimbursed, and this is what patients can already benefit from. But there are many more to come. The first one would be fibroblast activation protein or FAP, with FAP inhibitors labeled for imaging with gallium-68 and for therapy, for instance, with Y90. The target is fibroblast activation protein, and this is already in patients, as shown here. The study from Richard Baum, the patient treated with lutetium fibroblast activation protein inhibitor 2286. Pre-treatment scan here, the post-treatment scan. The fibroblast activation protein is most frequently expressed only on stromal cells and not on fibroblasts and not on tumor cells, and therefore this will require, in most cancers, combination treatments. Another one, and that's widely studied at Stanford, this is bombazine, the target being gastrin-releasing peptide receptors. This is for imaging in human trials, and also therapeutic trials are on its way. It's something that will find its place in support of PSMA-targeted treatment for instance, patients with high bombazine but low PSMA expression. Neurotensin has been targeted, and these are in phase 1 trials in pancreatic cancer. And this one is an interesting one. It's carbonic anhydrase 9. It's used in patients with clear cell carcinoma imaging data very promising with high standardized uptake values in all the patients that were studied at UCLA thus far. And of course, the therapeutic compound is already being developed and will be in clinical patients very, very soon. All this together has created a substantial market interest, with the theranostic markets now predicted to amount to more than $7 billion in 2025. So what we see during and after treatment with lutetium PSMA, which is of course the poster child of Theranostics, is this. Usually we get to see the good. This was the image of the year in 2018, Hoffman's group with Peter Mack. You see the pairs of studies, the left one always the pre-treatment and the right one the post-treatment, so pre and post. You see the numbers representing serum PSA levels before and after treatment. And you can see the dramatic responses in all of these patients shown here, with spectacular responses that of course gave rise to the great excitement of PSMA-targeted therapies. But we also have this one, and that's what we call the ugly, and that occurs in 50% of the patients or so. This is during treatment, pre-treatment scan, all the red, of course, tumor burden again. After treatment, explosion of the tumor load in this patient, and PSA goes up from 20 to 137. Same markedly increased tumor burden in all these patients after treatment. And these are the examples that we less frequently see when we talk about the PSMA-targeted therapies. But these are the data, 3 prospective trials. The first one was published from the Australia group, was a prospective trial, phase 2 trial in 30 patients, a PSA response, a drop in PSA in 57% of the patients. This was the UCLA trial with a PSA response in response to lutetium PSMA treatment in 37% of the patients. The good news was that PSA responders lived 10 months longer than PSA non-responders in both of these trials. And then came, of course, the VISION trial, randomized trial, prospective phase 3 trial, the pivotal trial, where standard of care was compared to standard of care plus lutetium PSMA 617. And the outcome, final result is shown here. The survival benefit in these heavily pretreated patients, a survival benefit of 4 months for the PSMA-targeted treatment group. In my view, this is not the ideal outcome. This is actually suboptimal. And I think we need to make a lot of efforts to do better than what has been achieved thus far. So success breeds complacency, and complacency breeds failure. This is taken from the whiteboard in Mike Phelps' office, who was originally a mentor, but then became a close friend of Sam Gambhir. If you're not uncomfortable, you're not making progress. This is the sentence on Mike's whiteboard. So how can we improve patient outcomes? And the key, I think, is here to understand the reasons for resistance. Part of it is radiation type. It can be injected activity with underdose. It can be target expression that can be low, target heterogeneity that can be high. And then, of course, tumor perfusion and stroma barrier can be other reasons why the drug doesn't get to the target. There are also biological tumor resistance mechanisms. It can be the mutational status. It can be the immune landscape. Prostate cancer is considered an immunologically cold tumor, and maybe we can convert it to a hot tumor. And then acquired resistance through DNA repair and damage response. Radiation type matters. This is the VISION trial data. This was the outcome that I showed you already. This was lutetium PSMA, 4-month survival benefit. And these are the PSA responses. As I said, greater 50% reduction in PSA and about more than 50%, and about 45% of the patients. When you look at actinium and alpha emitter, you get more profound PSA responses. This is a retrospective trial, so take it with a grain of salt, but also in a post-chemotherapy group like the VISION trial, you get a very profound, lasting remission and much improved cumulative survival when compared to the lutetium data. And there's an actinium trial from the same group in South Africa that looks at administered actinium after androgen deprivation treatment, so before chemotherapy, again with very, very excellent long-term responses, long-term survival, and with near uniform PSA 50 responses, namely in almost 100% of the patients. So the radiation type matters, and if it wasn't for toxicity, everybody would use alpha already. Injected activity matters. That is shown here, where you have the survival of mice. This is a preclinical study now. In the mice without treatment, low dose actinium, low activity actinium, survival goes up to 16 weeks. Next higher dose, survival goes up to 40 weeks. And then if you go to the highest dose, survival drops to 19 weeks. This is shown in the red curves, some with mice with excellent lasting responses, but now you get toxicity. But obviously, injected activity matters, and optimization of dose will have to come to really arrive at personalized and individualized treatment in prostate cancer patients using these methods. And that the radiation dose matters was already shown clinically. This is again by the Peter Mack group. They did dosimetry scans at 4, 24, and 96 hours after lutetium therapy. Here you see the wide range of tumor doses that you get in these patients. And it turns out that in patients who receive less than 10 gray on average to tumors, out of 11 patients, 10 were non-responders. And only if you get more than 10 gray into tumors do you get substantial reductions in serum PSA at week 12. So tumor radiation dose absolutely matters, and dosimetry is something that will come and has to come in the near future. Target expression and heterogeneity matter. This can be modeled again in murine models where you have some tumors with no expression, low expression, medium PSMA expression, and high expression. Then you treat with lutetium PSMA, you monitor tumor growth, you take the tumors out, and what you find is that the lutetium uptake ex vivo is highest in the one with the highest PSMA expression, that the DNA damage that you induce is highest in the same group, the ones with highest expression, and the tumor growth retardation is also most prominent in this group. Here, lesion-based heterogeneity that we modeled, 100% PSMA negative, and then a mix, 75% PSMA negative, 25% PSMA positive tumors, 50-50, 25 PSMA 75 positive, and 100% positive. We treat again, we look at tumor growth. In another group, we resect the tumors, and we look at ex vivo uptake. And again, the ones with the lowest heterogeneity have the highest ex vivo lutetium uptake, have the most profound DNA damage, and the most profound tumor retardation. And again, this has been shown in human studies already. This is taken from the therapy trial, Michael Hoffman's data. This was a randomized trial between cabazitaxel and lutetium PSMA. And if the whole body tumor SUV mean was greater than 10, then 91% of the patients responded with a significant PSA reduction after treatment, and also showed a significantly improved event-free survival. This was not the case if the mean SUV, whole body SUV, was less than 10, where you didn't see a difference between those with low and those with higher SUV mean. Same for heterogeneity. When you look at these scans, here you have high PSMA expression, and it's homogeneous. It's high throughout all lesions. In the middle, you have some with very high and others with low expression. And here on the right, low and homogeneous expression. And when you look at the outcome of these patients, the one with high and homogeneous expression had the best cumulative survival after lutetium PSMA therapy, while the ones with low and PSMA expression and homogeneously low expression had the worst outcome. Mutational status also matters, something that hasn't been studied very well. Here we modeled p53 mutations. So we knocked out p53 here, which completely abolished the radiation effect that was seen in wild type, where the p53 wild type mice responded with tumor growth retardation in response to lutetium treatment. Again, abolished in the effect abolished in the mice with tumors that had deep p53 mutations. And this translated into improved mouse survival. This is what radiation does. It delivers radiation to prostate cancer cells, and it causes DNA double-strand breaks. And that initiates a pathway of called DNA damage response, replication stress response. It's a compensatory mechanism, and it either results in cell death or tumor cell survival. And of course, tumor cell survival is not what you want. We took from mouse tumors tissue and did phosphoproteomics, and we showed that ATR and ATM, who regulate these kinases that regulate the DNA damage response pathway, that ATM and ATR were upregulated in after both lutetium and actinium treatment. There are drugs that can inhibit this activity of this pathway here. These are DNA damage response inhibitors, ATR inhibitors. When you give this to mice in combination with lutetium treatment, then you get tumor growth retardation. So combination treatments that in this case have not yet translated, as these ATR inhibitors are still in clinical trials, but these combination treatments make sense if they are rational. And just as an example, Roche recently purchased an ATR inhibitor for $1.3 billion from Repair Therapeutics. We also looked at the immune landscape because that provides another potential combination treatment, as shown here. Radiation increases PD-1 expression, leading to immune suppression. So we tested, of course, the combination between radioligand therapy and a single cycle and the PD-1 antibody. So we have 4 groups again: control group, antibody alone, actinium PSMA alone, and the combination of radionuclide therapy or radioligand therapy with an anti-PD-1 antibody. And as you can see here, the survival is best if you do the combination treatment. The controls lived on average 28 days. The combination therapy prolonged the survival to 51 days. We also looked at the consequences of radioligand therapy, and what we found was that when you do radioligand therapy, you increase the proliferating CD8 T cells in tumors while decreasing the number of regulatory T cells. You also increase M1 and decrease M2 abundance, so you really change the immune phenotype from cold to active and hot. And what we show here is that if you combine the radioligand therapy with the anti-PD-1 antibody, then you increase the percent of T cells invading the tumor significantly. So shift the immune phenotype from a more immunosuppressive to immunosupportive microenvironment. And then there's an alternative approach that we tried recently, and that is activating the cGAS-STING pathway, which senses DNA damage in the cytosol. Then via cGAS activates STING, and STING will increase the production of interferon to stimulate the innate immune system or the innate immune response. Again, STING agonists, as you see here, are already in early clinical trials. So it's not something that is esoteric. It's something that is pretty close to phase 3 clinical trials in combination most of the time with other immunotherapy approaches. So we modeled this again in mice with 4 treatment groups, untreated controls, radioligand therapy alone, STING agonist alone. And here 2 protocols of combining STING agonists with radioligand therapy and completely abolished tumor growth in this one model here and near completely in the other one when we gave the STING agonist a little bit after the radioligand therapy. But this is a very promising approach that we are currently investigating in further preclinical studies. So in summary, to overcome resistance to molecular radiotherapy, we really need to have more precise radiation. And to that, we will have to do dosimetry. Injected activity probably can be increased in many patients, or it has to be decreased in some to provide appropriate safety measures for the patients. Type of radiations, alpha radiation will become important. It's not only going to be actinium-225, it's also going to be lead-212. We will have to improve patient selections by looking at target expression, target heterogeneity. This can be done with PET imaging. We also have to select patients based on mutational status because we know that p53 mutated tumors will have an attenuated response to any kind of radiation. And then we'll have to come up with various translatable combination therapy to reduce DNA damage response mechanisms that actually are tumor protective, and also to enhance tumor immunogenicity to treat patients with various immunotherapies. So this is the future of nuclear medicine and theranostics. There are strengths and opportunities. We have great successes and visibility through diagnostic and therapeutic trials. We have highly innovative imaging technology with total body PET. We have imaging biomarkers for true precision medicine, call it whole body phenotyping. Theranostics is something that have given the field of nuclear medicine clearly a new life. Now we need to do the translational research to understand resistance and to develop combination treatments. There are significant challenges and opportunities. We need to expand clinical trial networks. We need to arrive at a point where we can study large patients cohort prospectively in randomized trials throughout many centers in the United States. We need to train the nuclear medicine workforce. The training is suboptimal. That was even suboptimal before Theranostics. Theranostic centers need to be available to train the next generation of what I would call theranosticians. We need to promote nuclear medicine as true precision medicine. Which other discipline can survey the whole body for the expression of the therapeutic target? It's really only nuclear medicine right now. And we need to create competent theranostic centers. With this, I want to thank our interdisciplinary team that consists of clinicians, clinical researchers, preclinical researchers from the fields of urology, radiation oncology. We collaborate with many other centers to really move the field forward. And with this, I want to thank you very much for your attention.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.